Thanks very much, Colin, for that fantastic illustration of what we're trying to do today. So, as Colin said, we'd like to welcome you and also acknowledge the traditional owners of the land. And we're really lucky today with the lineup of speakers. And as the sessions indicate, we would really like this to be a dialogue. So we've organised the session. We'll hear from 3 of our speakers, and then there'll be some time for question and answer, hear from the rest of our speakers, and then more time for question and answer. And Steve Allender will facilitate an interactive dialogue with you. So really put your thinking caps on. We want this to be a dialogue. To kick off the session, we're really lucky to have Dr. Colin Tukuitonga, who's the appointed Director General of the Secretariat of the Pacific Community in 2013. He's held several leadership positions across the Pacific and globally, including Associate Professor of Pacific and International Health at the University of Auckland, Head of Surveillance and Prevention of Chronic NCDs at the World Health Organisation, and former Chief Executive of the Ministry of Pacific Island Affairs, Government of New Zealand. He's the founding member of the Niu Arts and Culture Festival, Pacific Language Weeks, and is really eminently qualified, as I'm sure many of you have heard already during this week, to speak to this topic about the global and regional view. Thank you, Colin.
Thank you very much. I'm sure those of you who were here yesterday has probably heard enough from me, so I said to someone just now, I apologise if I repeat some of the stuff I said yesterday, and the challenge, of course, is how do you keep it interesting. The other thing I should say is that you could look up the figures on prevalence of obesity around the world yourselves, so I thought I would do 2 things. Just focus more on the Pacific, because that's my habitat, my place of focus at the moment. And secondly, to try and answer the points that the other Colin raised just now about the challenges that we face, the opportunities, and some thoughts. I have to say, if I was in Tonga and I was asked to make this presentation, ending obesity in 1 generation, I'd say, what, are you kidding? Do you not realize that 90% of the population are overweight or obese? How do you think we're going to achieve that? But this is, of course, the story of the Pacific. It's been described as the epicenter for obesity, and it occupies us all the time in terms of what it is that we should do. I think I showed this yesterday. This is just to remind us that NCD mortality globally is big and growing, and a lot of it is in developing countries. Half of the deaths due to NCDs is attributable to cardiovascular disease, but you're familiar with the full range of conditions that are included in this catch-all NCDs. Again, if we look at the mortality, the graph on the left obviously shows a dramatic increase in mortality from NCDs from 1990, I can't see very well, to 2020. Continuing decline in communicable diseases. And of course, the other one that's increasing, and particularly in our part of the world, is injuries. Road traffic injuries directly linked to increased numbers of cars, imported Japanese cars, often fueled by alcohol. But that's a discussion for another day. And of course, on the right, you can see for the European, the Americas, and the Western Pacific regions of WHO is without a doubt the leading cause of death. But even in Southeast Asia and IMRO, it's also the leading cause of mortality. If we look at selection of the risk factors, the bar on the right on tobacco use, we've just had a session on that. Again, you'll see in the Western Pacific, tobacco use in people aged 15 and over is very high. Similarly, EMRO, Euro, and Southeast Asia. In the Pacific, you will recall that it's a particular problem for us. Some of the islands, the tobacco use is in the 80% prevalence. And again, physical activity for people aged 18 and over on the far left is shown there. Here's the graph I said. I've shown this before. In Kiribati, 75, 3/4 of all men smoke. Similarly, Wallis and Futuna, French territory just north of Fiji, Tokelau, so on. Very high rates. And it's not declining, it's not coming down. Generally speaking, of course, men tend to smoke more than women. But if you look at Nauru, at French Polynesia, at Cooks, more women smoke, which again is something that we don't quite understand yet. But Vanuatu women, and I've made mention of this already, for some reason less than 5% in Vanuatu smoke. And if we understood why it is that happens, we might be able to package it and sell it, or at least share it. But without a doubt, smoking is our biggest public health challenge in the small islands of the Pacific. And we're not winning it, I should say. I made mention briefly in relation to injuries, alcohol, another problematic issue. And we are dabbling around the edges. As I said yesterday, we sign any declaration and every declaration, but we don't do a lot with it. And alcohol is one of those, causing significant social, economic, and health problems in many communities around the region. It's absolutely terrible. And it's by and large promoted by the alcohol industry, and there's very little by way of intervention to try and control it. This is a major, major issue. But this is, of course, the topic at hand, obesity. We are the world champions, along with Fijians as the world champions in rugby sevens. We are absolutely the world champions. Every now and then, Saudi Arabia creeps in at the bottom in number 10, but this is the epicenter of obesity in the Pacific. And as you can see, in males, in men in American Samoa, 80% are obese. The other 20% are overweight. So it's phenomenal. Pretty much right across the region. It used to be said that if you were in Melanesia, in Vanuatu, Papua New Guinea, Solomon Islands, you were relatively protected. In other words, the prevalence of obesity is not such a problem, but that's a myth now. It's a problem right around the region, perhaps with Vanuatu there on the far right. And again, I showed this yesterday, 7 out of the 10 countries with diabetes prevalence for people between the ages of 20 and 80 are in the Pacific. Very high rates of type 2 diabetes. And we're not talking, 10%, we're talking sometimes half the population have diabetes, and a significant proportion have pre-diabetes, or whatever terminology you use. There's been some questions around the accuracy of some of these figures, but I'm pretty confident that we have a significant problem with diabetes, type 2 diabetes across the region in both men and women, largely attributable to obesity. I'll just, again, the whole NCD issue in diabetes has significant development implications and costs for small island health systems where 80 to 90% of the costs are met by government. So, enough of the figures. What are the challenges? I mean, clearly, NCDs is a complex, multi-sectoral nature. It has a complex, multi-dimensional nature. And I often wonder whether the health sector is the right sector to be leading this. I mean, we've come from, single bug causes disease X, and we know how to fix that. We vaccinate, or we give them antibiotics, or do what we do, and you get on top of it. NCDs is not a health challenge, actually. If you think about it, we are the recipients. The health sector is the end result of failures in the food policy side. Too much free trade of what I call crap. Highly processed, salted, sugared produce. Most of the islands in the region, even though they're quite capable of growing and producing more of their own food, import about half. Tonga, Fiji. In Nauru, 90% of the food is imported. And if you know the Nauruan story, there's no prospect of them growing their own anytime soon. So this, people will say, well, maybe it's more complex than that. In my view, the whole scene with regard to obesity is the inappropriate and excessive consumption of highly processed foods topped off with sugar-sweetened beverages. And that, unfortunately, has become the norm in terms of diets for many of the people in the region. So I think that's a challenge. It's probably the biggest challenge. How do we overcome a complex and multidimensional challenge such as NCDs? The other challenge, in my view, is even though we know that, at least in our part of the world and many other parts of the world, it causes about 3/4 of all deaths. But I've often described the resources allocated to the prevention and control of NCDs as like trying to turn the Titanic with a canoe paddle. We are absolutely way short of the mark in terms of the resources required across the sectors. I'm not just talking about the health sector, across the sectors, to encourage and support agricultural policy that favors local production and consumption of fresh produce. We are way short. We've got lots of declarations, global declarations about this, that, and the other thing, and we have a lot in the region. And yes, I should acknowledge the fact that the small island governments are allocating the resources that they can. But I can tell you, and if you want the exact figures, the World Bank has just put out a report under the title Pacific Possible that tries to quantify the quantum of money, resources that we need to really mount an effective campaign against NCDs. This is one of our biggest challenges. The no-do gap is one that I borrowed from WHO. It's like a lot of things. We know a lot, but we don't do what we ought to do. For example, there's cost-effective medication for many of the NCDs, treatment of high blood pressure and so on. But most of the small islands in the region cannot and do not provide an assured supply of those medications, even though they have a wonderful essential medicines list fashioned upon the advice of WHO. So we are not applying the interventions that we know are cost effective. And this is what it's generally regarded as the no-do gap. And like a lot of things, accountability in this space is confused and confusing. It's not clear, as you can imagine, for a multi-sectoral challenge such as this NCDs, who is accountable? Because unless somebody, and I'm not talking about you account to me, it's about accountability to one another, that we've done the things that we said we're going to do. Because I mentioned earlier on that we've set targets. You know, you're very clear. I'm sure you're well aware of the WHO NCD goals and targets. But who's accountable? And that, to me, is one of the challenges that we face. Opportunities, I think it's fantastic that NCDs is in SDG number 3 in Agenda 2030. It is, of course, quite a broad goal, and you do run the risk of NCDs being perhaps not getting the attention that it deserves. But I do see, personally, I see the Sustainable Development Goals as a real opportunity, and specifically SDG number 3, and of course the related goals such as one around food security and ocean health and so on. In the Pacific, I have great hope in the roadmap, and earlier on today I shared with some of you who were here the tax hikes that have been applied by many of the island nations around tobacco, some as high as 70%. So I'm very hopeful that we'll continue to make impact. And we, collectively, governments and ourselves, need to report to the economic ministers every year on the progress we're making. So I'm very encouraged by this. Some of you might know I was on the WHO Commission on Ending Childhood Obesity. I commend that report, partly because I was part of it, but I do think they have some wonderful suggestions. I think we've got to get serious about obesity in children. If it's all too big and too hard, start with children. And there's some fantastic recommendations. Many of them would be familiar to you. As of today, the Pacific does not yet have a plan as to how we might go about putting this in practice. But be assured, as long as I'm at SPC, I'm going to continue to prod somebody until we start to do something. Grow, produce, and consume more is my mantra. And at SPC, given our work in agriculture and fisheries and a whole range of sectors, this is what we want to do, and one that we communicate with our members all the time. I wonder whether we are being soft on the regulatory approaches. People continue to promote this idea of self-regulation being the preferred option. I often regard that as putting the fox in charge of the hen house. I mean, I'm sorry, folks. I'm very cynical about this. I know in some sectors and in some areas, self-regulation is effective. But in the food space, in the advertising space, I'm doubtful. I think governments need to intervene more, personally. But anyhow, you might have a different view. So, just to finish off, I think there's a cause for optimism. I think that in a generation is being a bit ambitious, but it is possible. I think there's a general awareness of the underlying causes of NCDs and obesity. I do think, though, that the prevailing dietary patterns in many of the developing countries, and indeed in the Pacific, is one consisting of predominantly highly processed imported food. Somehow we've got to recreate a new set of norms, perhaps start with our children, that a breakfast of soft drinks and a burger is not good. Thank you very much.
Thanks very much for that great global perspective to kick us off. So just a reminder, we're going to have the talks first and then we'll have a full panel discussion. So I would like to introduce myself. It's a great pleasure to introduce myself. And I'd like to talk about levers to improve population nutrition. So obviously there are a number of elements required to effectively end the rise in obesity in a generation, and this is one of them. So if I could move to my first slide. Just to start with some acknowledgements and disclosures, particularly everybody in the research group who's participated in thinking along the way. And I guess to set the same kind of context as Colin, although you're all very familiar with it, I think it is important to take stock and remember why we're in the room. And one of the main reasons is because we have had this increasing prevalence, this rise in obesity over the past decades. And Colin talked a little bit about the Pacific, and I'm sure you've all seen the global numbers. So this again is just a context-setting slide from the Australian perspective. And we know that if we look at Australian adults in 1980, when we first measured data, about 1 in 10 Australian adults were living with obesity, and now it's over a quarter. So large increases over those decades. The other reason that I think it's really important that we're all in the room and interested to engage in this dialogue is because of the large inequalities in the distribution of obesity. And that's both regionally around the world, as we've just heard, between high and emerging middle income countries, but also within high income countries. And what this illustrates is, again, in Australian adults, the current status of the prevalence of obesity, looking at 2 quintiles of area level disadvantage. And as you can see on the right, that's the least disadvantaged or the most advantaged quintile in Australia. And you can see around 19% of the population living with obesity today. And if you compare that to the most disadvantaged quintile, you can see it's more like a third. And these are large differences across our population and, as you know, globally. And I think this is another reason why we really need to get to grips with how we're going to end obesity rising across the globe and within our communities. So as I said, I want to look at the levers around food. And I suppose when I was reflecting on the challenges and the opportunities, to me they're almost one and the same in this context. And this is a very well-known diagram, I'm sure, that the CDC put out. And it's kind of looking at all the different levers that we've got across food to intervene in population diets to eventually move them to healthier population diets. And of course it's set across the social determinants of health kind of framework. And what you can see from this, I think, which kind of gives rise to my challenges and opportunities, is that there are many, many areas that require intervention. And I'll go through those in a minute. But I think that also means there are many, many levers or many, many opportunities. And so while we need to do a lot of things and we need to make sure those things are internally consistent and coherent, that also means we have a lot of opportunity to move forward. The other large opportunity I see at the moment, which I think leads really nicely on from Colin's last slide, is I think we are actually, as I'll talk about in more detail soon, seeing momentum in this space. So this diagram, if you like, won't be surprising to anybody in the room, and that reflects the level of coherence and consensus that we're getting now internationally around what are the different things we need to do to improve our food system and to improve population diets. And I think that level of coherence and acceptance is a huge opportunity moving forward. So just to talk through a little bit about what that consensus is looking like at the moment, it's very well understood, and a good example is the Ending Childhood Obesity Commission report about what the factors are in these kind of different levels of intervention. And it's always set against a backdrop of an understanding that actually we need to intervene on the social determinants of health. So people are really clearly cognizant now that we need to have interventions across both income levels, capacity to achieve an education. We need to look at work balance and workloads. As was alluded to, things like trade start to then move much more into the macro level section of that picture. And so against this backdrop, we can look at some really food-specific levers. At the level of macro-level policies, there's a lot of discussion globally, as you'll know, around financial incentives, both to decrease the purchase of unhealthy food and drink and to increase the purchase of healthy food and drink. So I'm going to go through these policy areas, these settings type policies, and the interpersonal type programs and issues quite quickly, because I think you'll be across them. But what I think is important is to understand, as I say them, that they are so familiar to you. And to me, that reflects the position that we're at, which is really, we've moved quite a long way in the last 5 years. So we know we need financial type policies. We know that we need policies to address marketing of unhealthy food and drink, particularly to children. There's great acceptance. We need better labelling, informed consumers in a variety of different settings. We know that at the settings level, we really need to work hard to think about how healthy food procurement and provision becomes the norm across all government-related and community-related settings. And we know that more at the individual level, we need programs that make sure that everybody has the requisite education and skills to be able to purchase, prepare and consume healthy food. So that's kind of the template, and the excitement for me is that we've got a lot of acceptance of that template. Lots of variation at the level of the detail, but not much anymore at the level of the big picture. And so the way I see it is that we are kind of at this tipping point at the moment, and at the moment we all accept, like those scales, that our food environment is out of balance, and that we know that we are presented every day, our children are presented every day with unhealthy food environments that really have the accessibility, the availability, the promotion, the affordability of unhealthy food outweighing that of healthy food. But the excitement, and you'll hear this from some of the next speakers, we know that communities and organisations are really increasingly ready for change. It's starting to make sense to people that we should be providing our children with healthy food environments. As I've said, we're getting increasingly large amounts of evidence and consensus on what to do, and I think that that's something we really should be celebrating more than we are. And so I guess the question to me is not how we get the evidence, how we get the consensus. I feel like we're almost there. It's much more against that backdrop, how do we accelerate these changes at scale and obviously globally? So I want to reflect on two really important components of that just briefly, and hopefully that will give rise to some discussion later. One is that, oh sorry, that looks a bit higgledy-piggledy. One is that we really need to harness leadership. And people will have obviously noticed that over the last few years we've seen an exponential increase almost in countries implementing taxes for sugary drinks or financial levers against the purchase and consumption of sugary drinks. And what this picture should show you, and you can look up the reference if you want to see it in better format, is essentially in green all those countries that have implemented a tax on sugary drinks and the year roughly in which they've done it, and in orange those that have committed to do so. And as I said, you can see both a large number of countries and jurisdictions making that commitment and also an increasing number over the last few years. So that's a lot of leadership that we really now have an obligation to harness. We need to have a look at what is it that we can use from these countries and these jurisdictions making these changes to continue to spread these policies rapidly at scale across the world. Similarly, in Victoria, we've noticed over the last couple of years a rapid increase in the number of organisations that have decided to take a stand on sugary drinks. So what all these little icons tell you, and this is a map of the state of Victoria, are all those sites where the organisation has decided to either remove sugary drinks from sale or decrease their availability substantially. And these include a whole range of different organisations, sport and recreation centres, hospitals, local government jurisdictions. And there's been a rapid uptake in these policies by these community settings and these government settings over the last few years. Once again, the question I have is how can we now harness this leadership to make more of it, to gather the evidence, to communicate the practice, and to indicate and demonstrate the feasibility. And I think that is our positive challenge to take forward. In addition to all this change, I think, giving us opportunities to harness the leadership, I actually think it gives us an opportunity to build the evidence. Now, I'm just going to show you a couple of examples of evidence building. I'm not going to go through the detail because, again, I'm sure you're all across it. But what this implementation does is it allows us to build evidence around the impact of these policies, both on their intended health effects, so for example, purchase and consumption of sugary drinks, but also on other effects that may or may not be being touted as barriers to implementation. This one I'm sure you're all well across. This was the evaluation of the Mexico sugary drinks tax by Barry Popkins Group. And in brief, what it demonstrates is after implementation of the tax, there was a decrease in purchase of the sugary drinks that fell under the policy remit in the top bar, and not in the non-sugary drinks in the bottom panel. This evidence is critical for informing and supporting other governments, other jurisdictions to take similar action. Similarly, we've had a look with Alfred Health, which is a big hospital provider in Victoria, and they committed to removing sugary drinks essentially from site, which they call red drinks, to try and support their customers, so both staff and families coming through the hospital to purchase more healthy drinks. And what this shows you on the left is before they introduced their policy of removing those soft drinks or unhealthy drinks from site, and you can see around 40% of the drinks that were purchased were the unhealthiest or the red drinks. And after implementation of the policy, that had decreased to around 10%. This was really important information because it showed the retailer and the hospital that they could have a positive impact on what customers purchased in their healthcare setting. But what it also showed them, if you kind of look at the top line of both bars, it's the same point on the graph, and it demonstrated that introducing this healthy food policy had no apparent impact on retailer overall sales and essentially profitability. So we need to really harness the leadership I was talking about before to work out how to build the evidence both around implementation, health effects and any potential negative effects to communicate this at scale to generate the change that we're after. And I guess just to end, I wanted to go back to the start and reflect on what I think these changes are enabling us to do. And I think a lot of us are hearing a real change in the conversation, whether it's on Talkback Radio or in the media or in our local communities. More and more people are saying, oh, well, yeah, I guess it makes sense. I mean, we're a sports facility, so of course we should be providing healthy food. But 5 years ago, we would never have heard that. What's making sense today was not making sense 5 years ago. And I think we need to make a lot more of that. We need to applaud that, we need to be excited by that, and we need to build on it. So I just wanted to show you a few photos of these different settings around Victoria who are making these changes, not suffering for it, and actually seeing the benefits in their communities. And I suppose what it gives me hope for, and what I would love to have more conversation about, is I think it really allows us to build on this mantra that we've become familiar with, this idea that I think we can make the healthy choice, both the easy choice, and as Corinna Hawkes changed to, also eventually the preferred choice, and what I would say from an equity perspective for everybody. So thank you very much. So now I'm going to switch back to my MC role and introduce Steve Allender. It's a great pleasure to introduce Steve Allender. He's the Professor of Public Health and Director of the Global Obesity Centre at Deakin University, which is a WHO collaborating centre for obesity prevention. He holds a jointly funded NHMRC and Heart Foundation fellowship and is a chief investigator on an NHMRC partnership grant targeting childhood obesity, and also on NHMRC's Centre for Research Excellence in Obesity Policy Research and Food Systems. Thank you, Steve.
Seamless movement back and forward from presenter to chair role. Well done. Thank you very much for the opportunity to be here and talk. I'm hoping to talk about the idea of dealing with complexity at scale, and in part what I'm going to be doing is summarising a bit of what we heard, and in part looking forward to, well, what does it all mean and what happens when the rubber hits the road. I'm pretty conscious we're in the room with some fairly ferocious tweeters, so don't be afraid to boost my numbers. The Twitter address for Globe is down in the bottom left, and it means if you're looking at your phone, I assume you're tweeting and not bored and looking at Facebook. So one of the things we're asked to do is to give a perspective of where we feel the field is now, and then to talk a little bit about challenges and opportunities. And I think one of the things you've heard is that there's a shifting orientation in the desire to do something, but what you haven't heard yet, and what I think we need to own and locate, this problem is completely and utterly preventable. 100% of people in Fiji and Tonga, in some communities in Victoria as many as 50% of primary school kids, and yet it's completely and utterly preventable. Hideous graphic, don't try and read the right-hand side, but it's the Cochrane Review summary of some 50-odd interventions in kids, and it made a number of findings about what was promising in terms of obesity prevention based on several successful interventions at setting scale, interventions in schools that weren't intended to go to large population scale, but proof of concept. And the first thing it said is the response has to be multi-strategy and multi-level, echoing the point that Colin made a few moments ago, that these things are very hard to get on their feet. It takes a long time to get implementation on its feet, particularly if it's an external dose and a programmatic response. And it's hard to make them sustainable. What we learnt from a lot of the work we've done in Western Victoria is you get a success while the dose is there, and you get demonstrable reductions in obesity prevalence in primary, secondary and preschool kids. And as soon as you remove the effort, as soon as you remove the dose, those kids go straight back up to the base prevalence, to the comparison schools prevalence. So it's time to shift from we need an event in our system that is an external expert coming and helping us, to asking the question, how do we make the change sustainable? How do we change the default position to a healthy one instead of an obesogenic one? And we know that a single agency programmatic response is not enough. It's critical, it's essentially, we need our health services and our education sector leading the charge, but they can't do it on their own. I think a second message from Colin was governments will do what they can, but it won't be enough. And that led us to this idea of, all right, well, how do we embed what we know works in usual practice? How do we move from having to jump up and down and yell and say, please change something, to communities themselves leading the charge? How do we get people to embrace the complexity and think about the broader system and find their place in that system above and beyond, I'm a teacher, therefore if it's a kid's problem, it's a school's problem? One of the other critical lessons from the successful interventions in this region and in others is that local capacity is essential. If these things aren't owned locally, they will not work. If there isn't skin in the game from local leadership, local capacity, local resources, it will not work. And I echo the point Anna just made. If I asked you to write down a list of the 10 things we should do to solve childhood obesity in a generation, I'd probably get 200 different independent things, and you'd probably all be right. But the point is, we know what has to change, but we don't know how to do it. And the argument I would make is we're at the point in time where the question is not what, but how do we make these changes happen? Put a different way, it's actually pretty simple, this problem, isn't it? It's just a function of energy balance. We've just got to get kids to take less energy in and spend more. And we worked under this paradigm for 30 years and spent millions and billions on trials of one part of the energy balance. Gosh, there's a strong association between kids who are inactive and weight status. Let's randomise out everything else and just have something that gets them to be a bit more active. Well, it turns out it didn't work because the system fights back, and the pressures and the things we saw in terms of social determinants, there's so many pushing in the wrong direction that a single behavioural focus just isn't enough. A kid in school getting told to drink more water leaves that school, and I'm thinking about some work we did recently, set up a beautiful intervention, kids drink more water, here's water bottles, water bubblers, and a 7-Eleven opened 2 days after the start of the intervention over the road, $1 big gulps for the first 6 months. And we weren't adaptive enough to respond to it and say, well, hang on, that's probably going to have some impact on what we're doing. How do we respond to it? So we now know that this is too simple, and we now know we have to embrace the complexity. But here's the problem. Here's how the world's experts see the complexity of the drivers of energy balance. This is an old and boring picture for most people in the room, but it raises some pretty interesting questions. A minute ago, I just said the current state of best evidence says that we have to engage local capacity, we have to have local ownership and local leadership in driving the problem, at the same time as local leaders have to get their head around the complexity, understand it and use it. There's a fundamental gap between the expectation of what we're asking for and what may be feasible. So I'm going to put one of the major challenges, and I think this is the biggest one. If local capacity is key, local resources, knowledge and know-how and ownership are critical, and the whole community, not just single agencies, has to respond, how do we put the tools to make that possible in the hands of the community? Not how do we get a 5-year NHMRC grant to work in one community and a bit of it worked and then we're hoping a policymaker will pick it up and then they might run it somewhere else and then they'll forget about us. How do we give the community the tools to do the implementation as well as we can, to do the evaluation as well as we can, and to understand the complexity, the systems science as well as we can. And I would argue we've made big steps in each of those fields independently. There are journals on implementation science. There are journals on evaluation science. There are journals on systems science. What about the sweet spot in the middle? How do we put the tools in the hands of the community leaders so that they can do this as best they can? And that's a challenge we've been picking up, and I'll just give you an example of one thing. So this is social networks in 4 different communities. On the left is Shape Up Somerville and Romp and Chomp, which many of you will know. Unpublished data, please don't tweet. And it's the network at baseline in those interventions which were both successful. So each of those are the leaders in that community at baseline. On the right-hand side is the networks at baseline in 2 interventions that failed. So the question was, who in this community is interested in the health of kids and has power to change the way kids live their lives and how they connect to each other when they think about the health of kids? This is a diagnostic. If we're going to say the community, this is your gig, you have to take control of it, and they come to us and say, we'd like to do the work, if they don't have the minimal leadership structure to respond, any effort is wasted because it will fail. One example of a tool. Second example of a tool is something called Sticky, which I'm pleased to say lots of people in this room probably know more about than I do and use quite often, and it helps community leaders and community workers build the foresight model, but build that causal loop diagram for their community. So it asks the question, if we were to understand the complexity of the drivers of obesity in our community, what does that look like, and how do we use that to ensure our response is optimal? And I'll just show you one of those. And so this looks a bit like the foresight model. It's of similar size. This was built by the leaders of the community of Portland, which is a city of about 15,000 people in Western Victoria. And this is their version of the truth when they are asked the question about the drivers of childhood obesity in their community. The evidence base is here, sure, but there are things here that aren't in the foresight map that are far more important to that community than several of the things that are there. And what it does is provides that community access and understanding of the complexity, and then we work with them to say, if this is the beast and this is the evidence base, within your remit, interest and capacity, what's possible? Not what should we import from overseas and hopefully it works. What works in your complexity? What works in your system? We did this work maybe 2 years ago, and at the start of that, you know, the academic in the room was doing a lot of the talking. We did 95% of the talking to the room and the facilitation, whatever else, and we were supposed to build capacity, and we gave the tools and so on and so on. These communities now run events where they have 200 or 300 people coming and forget to invite me. I think that's a really good sign. I think that's a show that the capacity is being built. But we asked them to map onto this. Each of these are different sectors, so there's water and junk food and so on. And we said, where are the actions happening across your system? And this is what they showed us. Oh, hang on, sorry, I'll come back to it. And we asked them about that. But the other thing I want to say is about the opportunities, and this echoes some comments you've heard. People are now ready and willing to do something. The media, I think, has shifted gears. They're still publishing photos of people who are overweight, and that's regrettable. And they're still publishing pictures like the one on the left about us being a nation of fatties, and they're still pointing out which areas are worst. But tomorrow night, there's a public debate in one of these communities about whether or not there should be a sugar tax and whether or not they should have one themselves or go it alone or go with the federal government. There's genuine interest in moving this debate. The challenge is to how do we put the best science for prevention of obesity, implementation, evaluation and systems thinking in the hands of the community. That's the challenge we face. So there's 2 communities that have done some of this work, and just to give you a sense again, if I told you the Cochrane Review says multi-strategy, multi-agency, multi-action, in Portland, 200 things that they can track, but hundreds and hundreds more. Emergence right across all levels of the system, people doing things whether they're involved or not. A radio show dedicated to the Generate Sea Change initiative in Portland, and actions right across the policy sphere. Massive engagement from the local water company in trying to improve the taste of water, because it turns out it's the major driver of sugar-sweetened beverage consumption, because that community could understand the complexity. In Southern Grampians, Generate Change, 160 community leaders came together and started working together across a whole suite of different things to improve the health of their kids. a whole list of other things, and those who know the systems literature will have heard of this idea of emergence. You provide the seed and the support and things happen that you can't expect. School exclusion zones where you can't drop your kids any closer than a kilometre to the school. Automatic hour of passive transport every day, and on and on and on. Anna showed the picture at the bottom of this slide a moment ago. That's some of 13 health service leaders in Western Victoria who agreed to ban sugar-sweetened beverages in the health services because they could see a role for themselves in doing something about the complexity, and they were asked to lead on behalf of their community. So I'll bring you back to this picture and close in a minute or two. This was the starting point, and you now see this model in many different community arenas, not least the water company, the local health services, local milk bars and so on. And many meetings start here, and in work we've done in the ACT and in work we've done in other countries, with this map saying, all right, we have our agenda, which part of the system are we working on today, and how does it interact with the other work we're doing? And a year later, this is the actions that they could map that had resulted from the work. So instead of a single agency focusing on one part of the system, you've got a whole community focusing on hundreds of different elements of the system, leading to the things I showed you a moment ago. I'm going to close there, but I want to make a really critical point, and it's a sad one for the academics in the room. When obesity prevalence is back to 2% where it needs to be, it may not be us that does it. And in fact, it's probably not. Our role, I think, is to provide the tools for communities who want to fix this, and a community can be a room full of policymakers, a room full of new mums, health service CEOs. Once we've given them the tools to respond in a way that does the best possible science, we will win this. But it won't be us that gets the gold medal. The trophy will belong to those communities who make the change. Thank you.
Thanks very much, Steve. It's now my great pleasure to introduce Professor Marge Moody. She's a Principal Research Fellow at Deakin University, where she's the Deputy Head of the Deakin Health Economics team. In her role as a health economist, her work is focused on economic evaluation and priority setting, primarily in the field of obesity, NCDs and stroke. She's conducted the economic evaluation of a range of preventive interventions for obesity, including several large community-based obesity prevention projects based in Victoria, Australia and the Pacific. And today she's going to give us the perspective of who pays for prevention.
Thank you, Anna. So we're going to take slightly different tack here. My role is to talk about who should pay for prevention. So in Australia, we pride ourselves on probably having one of the best health systems in the world. Yet 90% of the deaths in this country arise from NCDs, from diseases such as cardiovascular disease, cancers, diabetes. And as we've heard before, most of these are preventable, and obesity is one of the leading risk factors for them. Yet there are few incentives in this country for insurers or providers to actually invest in prevention. Essentially, we run a fee-for-service model where the system pays service providers to treat the sick. So there's little in the way of financial inducements to try and keep people out of the hospital system. And there are few sources of funds available to pay for those things which we need to address in the obesogenic environment. And a lot of these things, as we've heard earlier, are actually outside the health sector. So here we have a national health system. We provide universal access to healthcare, funded through the taxation system. But most of those dollars are spent on treatment and management. So they go to hospitals, they go to GPs, they go to out-of-hospital care, they go to medications, etc. And I've shown there the measly proportion of our healthcare budget that actually goes to prevention. So in 2015 in Australia, it was something like 1.7% of the healthcare budget. and it's somewhat higher generally in other countries. So I think there are two challenges here. First of all, how do we reorientate some of the existing resources towards more of a wellness model with a greater focus on prevention, early diagnosis, early intervention, and secondly, to identify new sources of funding which we could tap into for prevention. So I'm going to focus largely on the second one today, although it's interesting to note the projects that Steve just talked about in country Victoria. There is no money actually available in those projects for interventions. Generally, those communities are reorienting or redirecting existing resources. Okay, so I'm going to come up with a couple of examples here of things that we could do. One is hypothecated taxes. So this is where we get revenue from a specific tax, but we dedicate it or earmark it to a particular type of expenditure. So the merits of doing this is that we as taxpayers then, you know where your money's spent rather than just going into a big black hole. It's more transparent. We're able to make a greater connection between the taxes we pay and the services that we're getting. It's also said that if we knew where our taxes were going, if it was a hypothecated tax, that we're more likely to be in support of increases in that tax if we support the purpose for which it's being collected. And it's about protecting resources, particularly health departments quite favour such taxes in that it's sort of putting a ring around their revenue and protecting it from other government departments. There are some criticisms, though, that total government expenditure may become quite unclear, governments fearful that they'll be lobbied for all sorts of causes to have specific taxes for different purposes. And some would argue that it's a form of tokenism. And the other thing, probably other criticism about earmarked taxes, are that they're very much tied to the business cycle. So if the economy is not going well and tax revenue falls, therefore the revenue that you've got available for your particular purpose is also going to fall. I've shown here some examples. First of all, on the left-hand side of the slide, some international ones. These are primarily around sugar and soft drinks, but shown some examples here where that tax is actually being set aside for a purpose that's related to improving health. So Philadelphia City Council, their soda tax they're using for improving childhood education and some going to parks and recreation. The UK government passed a soft drink industry levy. This is on the industry here rather than the consumer in 2016, and some of that's going to physical activity and also healthy eating programs, particularly amongst school children. Mexico, not all of it, but in part some of that's going to providing water fountains in disadvantaged areas. Then a couple of other examples. Palau, which is a small island nation in the Northern Pacific, 2016, it has passed legislation to dedicate 10% of its annual revenue from alcohol and tobacco tax to dedicate to prevention of NCDs. And another 10% will go to pay the subscriptions for healthcare coverage for disadvantaged people. And then also Thailand is doing something similar, 2% tax on tobacco and alcohol going to health promotion. On the right-hand side of the graph, I've given some examples of hypothecated taxes from Australia. Vic Health, which is our health promotion organisation in the state, which was originally funded in the first 10 years of its life from a tax on tobacco products. We have a health benefits levy, which is a tax on gaming machines in this country that's partly used to fund public hospitals. Back in 1996, Australia, under the Howard government, promoted a buyback of guns in this society following a major massacre in Tasmania, and there was a levy on personal tax specifically for that purpose. The bottom one there, recently there's been a major report, the Duckett report coming out in Australia, suggesting a tax on soft drink, and some of the options there were to, that the revenue, it was suggested that the revenue would be around $520 million. We could use it to increase spending on health. We could use it more specifically towards obesity prevention, or you could just use it to put it in the black hole and reduce the government's deficit. A new player on the block is social or health impact bonds. And this arises from, government having inadequate funds and the need to raise additional funds. So these are designed to raise capital from the private industry to support areas of pressing social need. So you're trying to get private investors to invest in health or social problems. So they not only provide a return on your investment, but they also target a specific problem. So your investment there is twofold. So you can see a quote there, it's all about investments that have or are intended to create both a positive social benefit as well as a financial return. So the Victorian government started to introduce a program like this last year. They ran a series of workshops and they've come up there with some key principles around this. So you obviously need a clearly defined problem. You need a problem that's where there are interventions that have a good evidence base. You need to be able to clearly measure the outcomes of that problem, the outcomes of your intervention, and you need an appropriate sharing of the risk and return. And there needs to be some measurable benefits back to the individual investors. So some examples here. One of the first social impact bond was in Fresno, California, back in 2013. And there they wanted to reduce the incidence and severity of asthma. Fresno was quite an impoverished and polluted community. So they were calling for investors to conduct remedial actions in the housing, the environmental conditions of housing in order to reduce the incidence of asthma and the incidence of admissions to hospital for asthma-related events. And the intervention led to net savings of $4.5 million, and they found the return on investment was about $1.60 for every dollar spent. New South Wales last year in 2014 started the New PIN program, and this one was about reducing the number of children in foster care by trying to return them to their families. And they called for an investment of $7 million in this project. It delivered a yield of 7.5% in the first year and a 60% restoration of those children back to their families. So the thing here was that they set a floor, a guarantee back to the investors. So the floor was guarantee investors at least 5% on their investment for the first 3 years if the program delivered below 55% of children going back home. And as I said, there's a Victorian pilot project program that is open to proposals that meet the principles that were on the previous slide. They're calling for them in any areas, although they do have 2 priority areas that they're particularly looking for proposals in. Another one that we probably haven't made a lot of use of in this field is philanthropy. So this is the desire to promote the welfare of others, where, you know, if you've got a lot of spare cash, that you can do that by making some generous donation. Philanthropy, generally you don't get anything back for your money except that you feel good about it, about your investment. So you're motivated by altruism and that you supported some sort of socially beneficial cause. I found this example. It was interesting that this Centre for High Impact Philanthropy, that's actually at the University of Pennsylvania. So there's actually a centre that sets itself up to provide the evidence to those people who want to be benefactors to good causes but don't know where to put their money. And there's an example there at the bottom where they invested in a range of obesity prevention strategies in Philadelphia. Another one that we probably have heard about is sponsorship. Philanthropy, though, is generally no strings attached, whereas sponsorship, on the other hand, generally entails some conditions. Sponsorship is generally designed to, you're donating money to a cause, but you're also expecting to achieve some of your own goals. So expecting to achieve particularly marketing goals around your product. So, you know, often a sponsor will expect naming rights to an event or a program. They expect their brand to be associated with that event, and they're expecting to attract people who go to that event or that program as new customers. And I think we've seen lots of examples of sponsorship both in this country and around the world, and lots of examples of probably unhealthy sponsorship, particularly in children's sport. There was some research done by the Cancer Council of New South Wales quite recently, where they showed that 8 out of 9 food and beverage sponsors of children's sports development programs in Australia were classified as unhealthy. I was in Fiji last week, and it was the Coca-Cola Games were on, which is the secondary school athletic carnival. Coca-Cola has sponsored the games, I think, for the last 20 years or so. I think they started off with sponsorship around $5,000. Now you can see there, they're handing over a cheque for around $750,000. And also last week, there was a public debate on NCDs in Suva, which 400 people attended, and it was around doing something around junk food. And the manager of Coca-Cola New Zealand was there. And there were questions from the audience about whether Coca-Cola would stop sponsoring those games. And the response was the usual response that A, there's very little sugar in Coke, and B, they couldn't see the connection between, anything wrong with sponsoring children's sport. So I don't think I'm particularly recommending that one, or not with some food companies. So in summary, I think we have an inadequate focus on prevention in our health system, and I think that's not only in Australia. We heard from Colin Tukatonga that the resources in the Pacific going to prevention are very low. So we need some new sources of funds, new ways to pay for initiatives, because as we said, many of these initiatives that we need to address are not health sector initiatives, they're initiatives outside the health sector. I think hypothecated taxes, which earmark revenue for a particular purpose, if we could get some of that going to obesity prevention, would be good. So these are gaining in popularity, although generally governments don't particularly favour them. I think social health impact bonds are new players on the in the market, but I think they're emerging with some potential. At the moment, they tend to be more on social causes rather than health causes, but they do pose some particular challenges. And philanthropy, I think, is largely untapped in this space. Thank you.
Thanks very much, Marge. Well, you're very lucky that we have two of the best speakers at the conference to finish our leadership dialogue, both speaking on advocacy from different perspectives. So Jane Martin first will be speaking from the national perspective. She's Executive Manager of the Obesity Policy Coalition, which is a partnership between Cancer Council Victoria, Diabetes Victoria and Deakin University. She's an honorary fellow at Melbourne University and a senior fellow at Deakin University, and she advocates tirelessly for policy and regulatory reform to prevent overweight and obesity. Thanks, Jane.
I have to really concentrate when I go up steps. I'm incredibly clumsy. I probably shouldn't even be riding a bicycle, but I'm hanging in there. So today I've been tasked to talk about something that I'm very passionate about, so I feel very privileged. And it's fantastic to see so many people here in the room for this session, which I think has been really fascinating and stimulating. So my role today is to talk about advocacy and the role of advocacy. I'm going to talk about, as others have, the challenges and the opportunities. I think there's a lot of opportunities, and I'm going to give a couple of examples of where I see innovation in advocacy. So we can go to my first slide. I'm just, oh, do I have to do it? Do I? The green arrow, oh God. There we are. I've sorted it out now, as long as you don't go to the black screen of death, it'll be fine. So the role of advocacy, obviously that's what I do. And as Anna pointed out, we have a range of macro level policies that it's the role of government to implement. And it is, communities have a really important role to play, but it's very difficult for them to stop junk food marketing on television, for example, or on Facebook or digital platforms. And so the kind of work that I do, and I'm sure many of you in the room do, is to raise awareness of the issues and the potential solutions with those who can make the change. And that's government, but that's also the community, because as has happened in one of Steve's community, that community's put up a petition for a sugary drink tax. And many of the levers, as I said, that are going to solve this epidemic, government holds the key. And it's not just the health portfolio either. So if we are advocating for a sugary drink tax, we need to be talking to the Treasurer. So it's not always sitting in one place. There's a range of players, which makes it more complicated if you want to influence change. And I think that one of the most challenging things that we have on our plate is countering industry. And I'm going to give you an example of that a little bit later in my talk. But I think it's really important that we expose the tactics of industry, that we correct the evidence that industry is presenting. One example is that the tax in Mexico hasn't worked. And we need to provide research and briefings around the true state of evidence. I think it's also really important that we have an ongoing dialogue with decision makers, not just politicians, but the people close to them, people in the department. With tobacco taxes, the discussions went on with Treasury for so long that the people who were attending the briefings as juniors, when they became senior, the same people were giving the same presentations. So, often you're not meeting the most influential person in the organisation, but you're forming that partnership and that relationship. And then you'll have that trust, and those groups will come to you for advice. Some of the challenges, we've already heard about the neoliberal philosophy that we have. The issue of reduction of red tape, so government's very reluctant to regulate. You sometimes hear that story. If you implement some regulation, you will have to take away regulation in another area. It's sort of this quid pro quo around putting into place legislation. And there's also that nanny state rhetoric that many of us are familiar with, and this is not just something that we're facing in Australia, we're all facing it. It's the same language, it's very similar issues. I think a key issue is that of resources, and I'd be really interested to know, is there anyone in this room that works full-time in obesity advocacy, obesity prevention advocacy? One. And we've got this really serious public health issue, and we're amongst friends and there's one person. So that's why we've got a problem. And I think that's really critical to make change. When I first started working in tobacco control in 1985, we had an executive director, we had a lawyer, we had 2 admin people, because in those days you had to write letters and send telexes, and a policy advisor. And that was all funded by Nigel Gray through Cancer Council of Victoria. He never made that public, but I found out later that I was actually employed by Cancer Council of Victoria. And we need that kind of commitment to build that capacity to make the change. I think another issue is we have gaps in policy-orientated research, and that's really tricky because there are a lot of questions that we are being asked by government that take time to deliver if you're relying on someone who has an NH and MRC grant. We need this evidence now. I remember asking somebody for something, they were doing some research, and they said, oh, I'll know in 3 years. And it was like, oh God, there'll be a change of government by then, and no one will care. But that's really difficult, and having a priority-orientated research agenda is really important, I think, because it's a long time to get these grant outcomes. And commissioning research is expensive, and we've done some of that. It's really useful, but it costs quite a lot of money. One of the key challenges we've faced in Australia is not having an agreed consensus around what actions government should be taking. And that's been a really hampering issue. And the ex-health minister, Nicola Roxon, who implemented plain packaging, has told us that loud and clear over and over. Get your act together, agree on something. If you're all saying something different, and Mike Daub spoke about this before as well, it's much easier for government to say we won't do anything. If you can't agree, it's kind of home free. So I think that's a really critical point. And the other thing is we kind of have in Australia in particular, we have cancer, heart, stroke, diabetes. Diet, obesity doesn't really fit anywhere. Tobacco control was kind of supported a lot by the Cancer Council and the Heart Foundation, but I think it's a little bit of all these organisations work, but it's not a key focus for any one of those. And I think that siloed approach means that diet, obesity kind of falls through the cracks a little bit. And I think we need to build new partnerships with others to fill that gap. Back to industry and their activities and their advocacy. These groups are very, very good at working together. They've been doing it for a long time. They're very, very effective. And Marge mentioned the Grattan Institute launching their report. Stephen Duckett went to Canberra and launched his report advocating for a tax on sugary drinks. That day, industry put out a media release saying that they wanted to work with government and be at the table and develop good policies to address obesity. And I'm just going to tell you now, I'm going to go through the list of who was on that media release. The Australian Sugar Industry Alliance, the Australian Cane Growers, the Australian Association of Convenience Stores, the Australian Sugar Milling Council, the Australian Beverages Council, the Australian Industry Group, the Australian Food and Grocery Council, and the Australian Association of National Advertisers. And the first few lines of their media release said that these groups contribute to $311 billion to the economy and represent 15% of the Australian workforce. That is huge economic power. And with economic power comes political power and influence. And you might not have noticed, but I didn't talk about Pepsi or Coca-Cola or Schweppes. I didn't talk about the industry groups. These are industry lobby groups. And these people are in Canberra talking to politicians all the time. Plus there's paid lobbyists. I think Coca-Cola has 4 paid lobbyists in Canberra. How can we work against that? You know, we are a mosquito, an absolute mosquito. So how do we work to take advantage of this situation that Anna's discussed and Steve's discussed? We have a fantastic community that's really motivated. We've done public opinion research with the community. The Australia Institute has as well. The highest sort of thing that people want government to do is address junk food marketing to children. And I remember the head of the Australia Institute said to me, "Jane, your problem is not a public opinion problem. Your problem is a political will problem." And I was like, "Yep, you got it." And so I think it's really important that we develop advocates in the community like Generate Change, who've done their sugar tax petition. But we also need to develop, community advocates, but we need to develop more public health advocates. We should have many, many more people in this room whose job it is to do advocacy. We need to develop advocates in the medical field. Really importantly, they were critical in the fight against tobacco. But we need to have advocates in economics, and we need to have advocates from the law. All my team are lawyers. They're very good at arguing. None are here today. So I think we also need to take lessons from industry tactics, and I know Rob Moody was telling me he's reviewing a book about that. But we need to learn from industry. We need to work smarter, and we need to work faster, and we need to be ready to respond because we need to fight back. And it's really important that these messages that industry are putting out are countered by respected agencies. And there was an example of Coca-Cola doing their response to obesity. They did that in New Zealand, and they did a campaign in Australia. And we organised a number of groups to come together and do a little list and write a letter to the board of Coca-Cola to say, if you really want to make a difference, these are the kinds of things you should be doing. And we got quite a lot of media around that campaign, and we got physical activity groups involved as well. Because some of the money that Coca-Cola was putting in was to promote cycling through Bicycle Victoria. And that, the CEO of Coke in New Zealand said the campaign didn't go down very well in Australia. It was about 80% positive in New Zealand, but it was only about 30% positive in Australia because we got together and we fought back. So I think that's really important. I also think we really need to develop the evidence base and have a resource, some sort of hub where all the evidence is synthesised, and that's a place where everybody can go to find out what is the evidence on whether a tax on sugary drink works. And it's a wiki and updated in real time, and I think that would be a really, really fantastic investment. And Anne-Marie Thao was talking before about this alignment between economic and health agenda, the economic agenda and the health agenda, and we've just seen that with AMP releasing a report this week saying that that sugar is an investment risk, and Credit Suisse have also spoken about that, and that's potential opportunities for partnership as well with those kinds of groups. So I'm just going to talk about 2 case studies before I finish up. So the first one is the Live Lighter campaign in Western Australia. This is a government-funded, public-facing campaign about this grabbable gut, and it's very similar to the Every Cigarette's Doing You Damage campaign, and it's been very, very effective. But what I think is really innovative about this campaign is they've really taken on advocacy in a very kind of careful way, because you're dealing with government money, to engage with the community. And this was done at the time of the Olympics, and the Australian Olympic team were sponsored amongst others by Cadbury, Coca-Cola and McDonald's. And they were advocating to get junk food out of children's sport. And so they put this advertisement in the local newspaper, which is really heavily read and very, very popular, and ran what I thought was the most fantastic campaign. And I think that's really a great idea to put that together with a public education campaign and have that policy advocacy side. And I think yesterday they said that it had about $600,000 worth of kind of free publicity around these kinds of issues. So really amplifying and adding value to what could just be a simple or a simpler education campaign. And this was another advertisement that they ran. And, you know, using social media, we've got the digital space. We really need to use that in the same way that industry do, and that around sugary drinks don't belong in sport. This was a really beautiful advertisement. And as you can see, there's a range of groups sharing the risk there, but Live Lighter has badged it. And a final example around, we've done a lot of work around sugary drinks. And the Rethink Sugary Drink campaign, I think, sort of highlighted the sugary drinks, the sugar in these kinds of frozen drinks. But Live Lighter very cleverly put the toxic fat inside the plastic container. I think that's really, really powerful and a really simple but clear message, and tying it again back to the mass media campaign. And finally, just to talk about Rethink Sugary Drink, this is run on a complete shoestring, but it combines that policy advocacy ask around an agreed consensus, which all the 13 organisations who are part of Rethink Sugary Drink have signed up to, and that's addressing the kind of policy changes that Anna was talking about around marketing, around taxing sugary drinks, around availability of sugary drinks in schools. And this is an example of some of the work that we've done with the Victorian Aboriginal Controlled Health Organisation with the Aboriginal community around sports drinks, and sports drinks are gammon. So that's had a lot of reach through that community. It's really helped that community go and do more. It's given them the imprimatur of having the partnership behind them, and we've given them a lot of support to be able to make those advertisements and really get that issue out into the community, that if you play sport, you don't need to have these sports drinks, they're full of sugar. So there are a couple of examples of where the advocacy and the public education kind of combine, and I think that's a really good tool to engage with the community and get them part of the discussion and get them behind and able to be engaged in the policy change. And this is another example of all the partners in sugary drinks. So you can see there's a big group of them, and there's a link there if you go to the website to the consensus on that about who we are and what we represent. 2 weeks ago, all the organisations, 10 of the organisations committed to the policy of a tax on sugary drinks or a health levy on sugary drinks, and they announced that. That's a really powerful statement, and there's been a lot of trust developed over the period that Rethink has been established. I remember talking to the Dental Association saying, would you support a tax on sugary drinks about 5 years ago? And they said, no way. But having been part of that partnership, having sort of engagement with a large platform and a large group of people, there's a lot of trust, and they were very happy to commit to supporting a tax on sugary drinks. So you can really build relationships and build support for broader policy reform by creating those partnerships and working together, and I think that's a very, very powerful thing. Finally, my brush with fame. Showbiz, we don't get enough of that, but this was a film that was made by Damon Gamo called That Sugar Film. It was pitched to a whole lot of philanthropics before it was finished, and a number of philanthropics funded the film. They pulled in a whole lot of people to do outreach as part of the film, and the Obesity Policy Coalition was part of that. And we went to screenings with Damon, we talked to communities. It was really interesting, so I really got to interface with people, and once they saw the film, and it was a film about how Damon ate a lot of processed foods which were high in sugar that you might not think were high in sugar, and put on quite a lot of weight and developed the precursor to fatty liver disease. But it really, when communities were watching that film, then they wanted to change their canteens at their schools. One grandmother came up to me and said, oh my gosh, I've been giving my grandchildren Up and Go. And it really started that discussion around food, what is healthy, what isn't healthy, and I thought it really engaged the community, and it was a really, really fantastic thing. And I got to meet an actor. It was quite thrilling. But see, clearly I don't get out enough. But that was a really sort of interesting way of getting outside your comfort zone, trying something different. It really opened my eyes to and introduced me to a whole lot of different potential partners, particularly the philanthropic community. So it was a really interesting concept. Thank you.
Thanks very much, Jane. So now we'd like to come full circle. We started with the global and we're going to end with the global. So for the global perspective on advocacy, I'd like to introduce Sandro Di Maio, who many of you will have heard already during this conference. He co-founded, as you know, the millennial global social movement NCD Free, and then he founded Festival 21, which is a public celebration of our collective challenges. Since November 2015, he's been medical officer with the Department of Nutrition for Health and Development at the WHO in Geneva, and he loves food and lives for positive social impact. Thanks, Sandro.
Great. Here's the clicker. So I don't know about you, but I loved the introduction and the concept that we're all pieces of Tetris, a bit of a Tetris nerd. And then I couldn't help but start thinking, which piece am I? And then I thought, why not get everyone to be a piece of Tetris to wake you all up for the last half an hour? So everyone stand up. And I can only think of about 4 pieces. But so first of all, there's this one. Then there's this one. Then I think there's this one. Then there's this one. And then we're going to try, ready? This one. Oh, I can't. Good luck with that one. All right, take your seats. Thanks, Colin. So I'm going to talk about global advocacy for prevention, and I'm going to try and do it quickly so that we have some time for the panel, because I love when we're all up on stage and answering your questions. So why is prevention so difficult? Well, for a lot of reasons. And we've been through many of them in the last couple of days. First of all, we're talking about tomorrow's fallout today. Nobody likes to, well, many of us don't like to save for tomorrow. When we're out and it's like, would you like dessert? We think, ooh, I'd really love the creme brulee. I'll worry about the waistline tomorrow. And at a policy level or at a national level, the macro level, that kind of just adds up. It's almost an ingrained part of being human in many ways, and it's well studied. So first of all, we're talking about tomorrow's fallout today, something that probably won't happen for another 20 or 30 years for many of us, and when we're talking about kids, maybe for another 30, 40, 50 years. There are very complex scientific underpinnings. Anyone who says we don't have enough evidence to start acting is being completely untruthful, and they're probably funded by industry. But we need to acknowledge that it is very complex science that underpins obesity, and we continue to learn more and more, not about whether we should act and not about what we should even be doing, but more and more science continues to build on the importance of acting and the importance of taking the action that we know we need to do. There's a lot of confusion out there in the public. I watched Insight last night. I love the show. I was finishing my presentation at the time, but I got distracted because the presenter started saying to one of the participants, one of the experts, oh, you're saying different to what this expert's saying. Your website says this, but your website says that. And it was a good example of where if I was a member of the public and I wasn't sitting there wanting to throw things at the TV screen as an expert or an emerging expert, I would have been pretty confused and thought, well, who do I trust? One person saying one thing, another person saying another. And instead of everyone saying, well, look, actually, there's a lot we agree on, and let's focus on that, the media and the experts, we got into a big conversation about how there are big differences in what everyone is actually, the fundamental recommendations that people are making, which we shouldn't still be probably having on national television. And this leads us to the fourth point, because we have very strong countercurrents. As I said this morning, this is not a mosquito. This is a vector. It's a very active vector of disease. It's a vector that has a lobby group. It's a vector that has 4 lobbyists in Canberra, as Jane said. It's a vector that will sue our governments for taking action. Very often there are aligned interests, but they for some reason are diverging. It might be personal characters, it might be the ways that people, one person wants to focus on A with a little bit of B as opposed to B with a little bit of A, or I want to use avenue C to get to B, and that ends up being the focus of the discussions as opposed to the fact that actually many of us in nutrition and way beyond nutrition are all agreeing with the same things. We very often overlook actually the perspective of the people we're trying to talk to, and instead we just talk as though we think in the way that we would like to be talked to. So we kind of overlook the perspective of the audience that we're talking to, and I'll talk more about that in a second. And probably the last one, which I've seen a lot of in my short career, is the fact that advocacy continues to be a dirty word in the academic community to a large degree, certainly in the global governance community to a certain degree, and in many other communities. Advocacy is seen as something that's kind of soft, and it's something that you do if you can't make science. And I think that that's wrong, and I think that's probably becoming pretty clear to the global community now. So my recommendations, very quickly, based on my experience of founding 3 social startups and now working at the UN in Geneva at WHO. First of all, we need to be much smarter about our global advocacy. What do I mean by this? Well, I mean that they bring summer and we bring a confidence interval. I don't think I need to say much more than that. We need to make our messages simple. We need to make them relatable. We need to make them positive. I mean, don't get me wrong, I will not ever have another Slurpee again. I probably wouldn't have anyway. But in addition to those important messages, we need to make them positive and we need to make them inclusive. And there were some great points that came out around leveraging children as a really important entry point into these discussions. Because language is really, really important. And in fact, language can be a non-starter. And we talked about this morning again. 2 words the public possibly could not hate more, sin and tax. We put them together and then we try and say, this is what we think will solve obesity. Reformulation. Again, what are you going to do to my food? I like my Mars bar as it is. You want to touch my Mars bar? It's like, maybe we need to kind of explain it rather than just saying we need reformulation. We need to actually explain it in words that the audience understand, that the audience can actually connect with, maybe even that's slightly emotive. And bans on marketing to children. I mean, this should be easy. You speak to the Nordic member states and you say, why do you have bans on not just advertising junk food to kids, but ban anything, marketing of anything to kids? And the Nordic member states say back to me, well, because it's the right thing to do. Like, why would we market to kids? They're kids. That's not right. We don't send them to war. We don't let them choose, they don't get to drive. They're still forming their impressions of the world. They're impressionable minds. Why would we advertise to them? Why would we be trying to influence them with commercial gains at the core? Second is we need to be far more collaborative. And there are not many people in the world that I've met so far. There are some in this room, but there are very few people in this world that truly believe deep down and embody the concept that success in others is success in us. But the problem is that we're facing commercial interests and we're facing a very organised, collaborative group who have a lot in common, will put their differences aside, whether they're trying to sell X or Y or they've got different, in fact maybe the same product in different market shares in the same products. They'll put that aside for the common gain. But unfortunately, all too often I see that it's actually the public health side that are not able to put our differences aside, not able to find a common sort of point on the horizon and say, look, we might not agree 100%, but we all agree that that is what we're aiming for, that would be a great start. That would make a huge difference. So let's forget all the rest and let's aim for that and let's make sure that happens. And it's not just within sectors and it's not just across relevant sectors. So we're doing a lot of work at WHO. I'm doing a lot of work at the moment trying to link the fact that globally we can get a lot of money mobilised for maternal, child and adolescent health, but we can't get a lot of money mobilised for child obesity. And that seems strange to me because maternal, child and adolescent health is the prevention of child obesity. Now, the big philanthropic funders of the world may not realise that they've already got skin in the game in child obesity, but they have. So we need to make sure that at least they're not doing harm. Maybe we can tack something on in the agenda that we want, or possibly we can actually work towards what we call double duty actions that will affect both forms, both extremes of malnutrition. And also looking for new irrelevant sectors, and the classic one for us would be, and I spoke at the Doctors for the Environment Australia Congress on Sunday and made the same appeal to them. A low carbon city looks like a low cardiovascular city, a low cardiovascular disease city. And largely a healthy diet is a sustainable diet. So let's find that common ground, and instead of you being frustrated because they have 10 lobbyists and you have one, and us being frustrated because they have 10 lobbyists and we have one, let's band together and at least we'll have 2. We've talked a lot about the Sustainable Development Goals. It's a new, very complex agenda, but there are lots, this should be the menu for us to look at and say, who can we be working with across that agenda? And really aligning with all of the different actors that are trying to achieve the Sustainable Development Goals. The whole concept of the SDGs is that they have converging indicators at the end. So there are single measures that we're going to measure that will actually reach or reflect the achievement of multiple goals. It shows that you can achieve multiple goals with single interventions. We need to find those, we need to find the other people who want those, and we need to work with them to achieve them. The next is we need to be honest. Now, some say we live in a post-truth world, and we need to continue to have not the high ground in the sense of an ivory tower, which is very easy to have, but we need to continue to be absolutely scrupulous in being based on facts and on evidence. But really importantly, we need to be guided and not lost by the facts and the evidence. And what I mean by that is they bring summer, we bring a confidence interval. We need to be bold. Richard Horton, the chief editor-in-chief of The Lancet, came to WHO and was very bold, told the global NCD community that we need basically the equivalent of a defibrillator, one of those kind of clear, in the hospital. We need to wake up. We need to be much more assertive. We need to be much more, maybe even ruthless in many ways. We certainly need to be more bold. Diet is now the leading risk factor for disease worldwide. Diet is also, or our food systems are also, the single biggest driver of greenhouse-related gases. The two biggest problems facing our planet are deeply linked, and very often I think we're way too polite in the way that we communicate them, the way that we respond, the way that we talk about them. Our planet is at a tipping point, but so are our populations. There is a biological tipping point. Once you become obese, it's much, much harder to re-achieve a healthy weight. We need to be focusing on prevention. We need to be focusing on preventing obesity in kids. And we need to be much more passionate, much more angry, and much more focused in going about that. Maybe don't tweet this. I might get in trouble. I didn't include it this morning, but I think it's important to know why we need to be more bold. This was something that was leaked through Coke Leaks late last year. And there are two figures on the screen. One shows a mapping that was done by Coca-Cola Europe of all the public health policies that are currently underway or in process or being discussed in Europe. And they mapped all of the policies that are underway to improve public health, and they worked out which are the ones they need to watch, which are the ones they need to prepare for, and which are the ones they need to actively fight back on right now. And this is an internal document that got leaked. And you can see sugar taxes are up in the top right-hand corner. True pricing is up in the top right-hand corner. And then we also saw, obviously, last year that the enormous level and number, breadth of organisations being funded by Coca-Cola around the world. They've now released them onto their website. But again, hundreds of organisations, individuals that are being funded by these companies. Now, whether it influences what they do, we can have that argument. But we need to be really clear. This is not conspiracy theory stuff. This is just the reality. And they have a responsibility to their shareholders. They have a fiduciary responsibility to their shareholders to return profits, nothing else. And we need to understand that. And we have a responsibility to protect the public and to protect children. So we need to be just as organised and just as ruthless as I would argue they are being. We need to be more strategic. So Jane talked about it. There is a global movement, Anna talked about it, there's a global building movement around progressive pricing policies, true pricing for sugar-sweetened beverages and sugary drinks. That is a great policy window that we need to get organised and jump through as an Australian community. We need to learn from other sectors and also understand the concepts of brand and brand associations. When we launched Festival 21 here at the Convention Centre and got 5,000 people to turn up to a festival basically about climate change and obesity, but we pretended that it was about food to get them all through the door and then sprung it on them. They loved it, it was fine. The way that we went from unknown brand to 5,000 people on the final day of COP21 on a Friday in December just before Christmas was largely through brand associations. The brands that we put ourselves up against or next to, that we piggybacked, were those that were going to get us where we needed to be. So they were Broadsheet, they were the Saturday Paper, they were Aesop, they were National Geographic. They weren't health organisations, they weren't climate organisations. They were all there, but they were not the ones that we associated the brand with. We had a clear message. Talk about something that we cannot get our societies to talk about by wrapping it up in something they love. And we had a very clear audience that we were going after. I promised that I'd be quick, and now I'm not being quick. So, be different. We need to change our language. And I wrote this down because I remember I had a conversation with Michael Wooldridge years ago, and he said, like, it was one of those weird moments where you're sitting in the coffee shop and Rob Moody goes, "Oh, Michael, Sandro." And I was like, "Oh my God, that's Michael Wooldridge." He's the ex-Minister of Health, in case you're wondering. Okay, it's just me, fine. And he said, what would you do for the country or something? And I started waffling on about social determinants of health. Really good, but not the right message for him. Because I realised that while social determinants of health and health in all policies and malnutrition in all its forms sounds really good to us, it doesn't sound very granular or specific to a policymaker. They're like, yeah, health in all policies is great, but which policies? And malnutrition in all its forms is great, but what are you talking about? And social determinants are the same. We actually need to talk about what we're talking about. So, I'm increasingly no longer talking about NCDs when I speak to people. Because rather than talking about the problem, or rather than talking about the big, long word that actually was framed around what it's not what it is, because it was built 100 years ago when it wasn't a problem, but now it is, I talk about the solutions, which is food. And I talk about something they love, which is food. And I talk about something emotive. You guessed it, it's food. Or I talk about health. Best mandate. I mean, come on, guys, we have like the best mandate. Health. Everyone loves health. Who's going to be like, "Oh, you're from the health group, aren't you?" It's like, it's health. And kids. We've talked about it a number of times now, but kids are a great way of starting the conversation and getting these policies drafted, because people are not going to say, "Oh, that's nanny state," if you're saying you shouldn't be able to advertise fast food to a 2-year-old. But they will say it if you say, "We want to ban fast food advertising to you." But eventually they'll go, "Hang on a second, you're banning fast food advertising to my 2-year-old. That makes sense to me. because you're manipulating my 2-year-old, and that's not okay. But why is it okay that you're manipulating me? And then the dial starts to move. So finally, again, I want to offer something that we're working on at the global level, an example of advocacy. In 2016, WHO, along with the FAO, of which I'm part of a working group, launched the Decade of Action on Nutrition. This is UN-led, so every 2 years we have a direct line to the Secretary-General and the heads of state around the world to report on how we're going in meeting the objectives of the Decade of Action on Nutrition. It's member state driven, so countries are making commitments to achieve the NCD targets, the Global Nutrition Targets, the SDGs, and even other commitments that they've already made. It's a way of bringing them all together into one place and giving us a time-bound window of accountability. It's around setting, tracking and achieving those commitments. We're talking about all forms of malnutrition, so obesity and NCDs, as they are part of the SDG agenda, they are also a big part of the Decade of Action. And as I said, this is not separate to the SDGs, which are not on the stage here, they're next door. This is a way of achieving focus and driving impact towards achieving the Sustainable Development Goals. And these are the 6 action areas that we're talking about. I will stop there, and I don't know if have we got any time? I'll stop there and hand back to the boss, Anna.
Thank you, Sandro. So we set a pretty ambitious agenda, ending childhood obesity in a generation, and that was deliberately ambitious. And then we set a pretty ambitious presentation schedule, which was we would talk for an hour and then have a panel for an hour. Reflexivity not being our greatest skill, we didn't think academics with PowerPoints might talk over time a little bit. We want to be respectful of your time. We are going to be here after the session finishes, but we have time for 3 or 4 questions from the floor that I will definitely direct away from me. Are there questions from the floor for any member of the panel? And I know there's a huge amount in what we've just covered. I understand that, but I also think there's a great cause for optimism and hope. I can see a question emerging over here, I think. Are there any questions people or points people would like to raise? Thanks, Ron. The mic at the front.
Thanks so much. I'm sorry I missed the early ones, but I heard you before. But Alessandro, you pointed out a couple of things. One, the myth of advocacy in food. We actually have 22 million food advocates in this country, and certainly the work that I was doing in this area, everyone's an expert in food. The thing is harnessing that power, and you've given us a plan for that. But I was just reflecting on some of the other ones about, we've seen some of these spats. This is an academic forum. We're supposed to fight about the evidence and those things. But you mentioned that last night you saw how 2 academics were having it out in public. Could we have a Melbourne Declaration where academics would stop fighting in public about infinitesimal differences of point of view, and we in fact said, too much food is not good for you? I mean, it's not hard, but we get it wrong all the time and we're ruining our message. I'd really like the panel's thoughts on how do we straighten out the advocacy nonsense that we're actually destroying ourselves.
I might give Jane first right to reply and then Sandra, if that's okay.
Well, I think you should have those. I think those arguments are important. Where are you, Rob? Did you? Oh, there you are. I think those discussions are really important because I work with lawyers. We have a lot of discussions. I always think it's better to have it inside, in the house before you go out, and you're taking something to a politician because you've got to get yourself sorted. So I would argue that we need to have more dialogue, that it's important we're having those discussions, that all the right people are in the room, and that we do develop agreement. And that's trust and time and building relationships and partnerships and collaborations. And I think we need to do a lot more of that.
And there's something I'd recommend called the Victorian Healthy Eating Enterprise, which I think actually is a pretty good representation of lots of stakeholders doing the hard conversations in a fairly safe way. Sandra, do you want to add anything from the global point of view?
No, I don't have anything to add. That's great. I think it's a great point, great answer.
Thank you. Up the back here. You might need to come to the microphone if that's all right, please. Thank you.
Thank you all. Plenty has been said about the need to, understand corporate vested interests and, place safeguards between the research and funding and all of that. And I absolutely support that, and I think it's vital that we continue. What hasn't been talked about is corporate interests who have a different kind of vested interest, and that is an interest in having more productive employees, healthier employees, and so on. And there are plenty of those. In the case of alcohol-related harm that I'm interested in, the shopkeepers along the street up from the pub who are sick of cleaning vomit off the windows. They've got an interest in reform of regulation. I just wonder, so we've got the public and we've got the government sector and NGOs and the industry, which we have to manage very carefully. But I think there's a lost entity of the corporate sector that has interests that align with the public good.
So I might respond quickly, and then Anna. One of the things that we're doing with the work we're trying to do is map the complexity, but the starting point is not, righto, let's get the academics in the room and map the way they see the system. The question we ask is, let's get all the community leaders included, business owners, pub owners, and the other usual suspects, municipal leaders in a room, get their version of the system. And in doing that work, they start understanding the common leverage points. So that the exact change you get is, hang on, we actually see a few of these problems the same way. And if we believe the health of our kids is an important thing to do something about, if we believe the health of our workers is an important thing to do something about, I'm not going to help you increase tax, but I'm going to help you lobby for a safer street or for a greener environment. So actually one of the strong messages that's coming through across, I think, all of us is the need for that alignment and common agenda. I think that's a reasonable thing. Anna, do you want to add anything?
I really would just support both the question and what you're saying, and I think the question kind of reflects, I guess, my optimism about where we're at, that I think, we've sort of moved now to a point where we can start saying, well, of course we should be having all these other collaborations and all these other connections because we're starting to sort out some of the things that looked so hard 5 years ago. So I think your question kind of is prescient of what's about to come. And there are leading organisations, like there are leading workplaces that see that worker health is critical, and they are making changes to food and activity. But we need to go much more broadly, and a bit like Sandra was saying, with all those other groups. And I think you will see that, definitely.
Thank you.
Sandra, just a quick comment. In terms of the private sector, you're right, we very often take this very naive approach of like the private sector is bad, which is not very helpful. Because the private sector includes smallholder farmers, it includes primary producers, it includes a huge amount of people who are actually, as you say, have strongly aligned interests with our end goals. I've had some great experience working with health insurers, for example. When we originally, I don't have a role in NCD Free anymore as I work at WHO, but when we originally founded NCD Free, it was crowdfunded, but then we moved actually to a health insurer that funded it because they're a not-for-profit mutual, so all of the members put money in and that funds the platform. It made huge sense to partner with them, and they have very, very, very deep pockets that I don't think we're fully taking advantage of. The other thing is not just understanding that there are different types of private sector, and there are actually parts of the private sector that we possibly can work with, but also then layering that with the policy process. So it might not be appropriate to partner with a food retailer when you're developing, in fact, I would argue it's not at all appropriate to partner with a food retailer in any way when you're developing a food policy. But there may be a way of partnering with them in the implementation stage right at the end, or with other parts of the industry, it might be possible to partner with them in the implementation of a policy, but not in the formulation of the policy in the first place. So we should be more nuanced in our approach to the private sector and think about it as, conflicts of interest and where in the policy process.
Thank you, Sandra. One last question, because we are at time.
Yes, sorry, my name's Paul Freeman. I'm from University of Washington, Seattle. I'd like to bring us back to our first speaker. I was a little bit disappointed that he was feeling so negative about things. I'm particularly interested in community-based primary health care. we know there's good evidence that child nutrition can be addressed successfully by care groups and by women's participatory groups. And he also, in a number of these projects in very poor countries such as Cambodia, projects have helped the women and the men in the communities working together to develop their own food supplies and gardens. Even with advocacy in the countries he talked about, there's no good, advocacy is good, of course, but then how can people actually implement it? And I was just wondering and we also know about the Barker hypothesis. Malnutrition in children leads on to NCDs in adults. So I was just thinking, what about an approach of, and I don't know island communities in detail, what about an approach of helping support women's groups in a family approach to address NCDs at the community level and also to provide, do their own gardens? Given that most people get their food through stores and as he said, the government is very reluctant to produce local produce itself and also reluctant to upset the firms selling in stores. Just something.
Thank you very much for the comment, and I'm conscious I don't want to have you here after when we promised we'd finish, so that may be a conversation we'll pick up at the end. I want to leave you with a challenge, although, and I want to ask you to reflect on what's been 2 hours of fairly wide-ranging territory with a lot of challenges and a lot of opportunities. And from my point of view, I honestly think we are going to win this battle. I really do. I'm just not quite sure how yet, but we'll do that together. I'd like you to reflect on what you've heard and think, what is it that stands out about what I just sat through, thought about? What is it that excites me, inspires me? What am I worried about? What does that mean for my day job? If that's what stands out for me, what does that mean for what I do and how I fit in? And therefore, what is the direction for prevention for the next 50 years so that in 50 years' time, we look back and go, can you believe prevalence of obesity was at 100% in some countries and it was 50% in some of our kids? Isn't that amazing? And I want you to think, what's the challenge we took on and beat so that we look back in 50 years and go, of course, we're always going to win because we took that approach. What I'd ask you to do is to think about that and leave those reflections, interpretations and directions on the Twitter account at @globe_obesity so that we'll be able to share them and we'll harvest those and put them on the website, but it'll be somewhere where we can all see them. So in closing, I really want to thank each of our speakers who've made huge efforts to be here and to toe the line, less so to keep to time, but I think we can probably forgive them for that. I'm also very grateful for your time and your energy. And in closing the session, I just want to say thank you very much and please put your shoulder to the wheel because we will win this fight. Thank you.